Principles of Virtual Nursing is our episode topic in this special Nurses Week edition of the BRG Nurse Executive Podcast. Rejoining us as guest is Dr. Katie Boston-Leary, Senior Vice President of Equity and Engagement at the American Nurses Association. She's here to discuss ANA's recently released guidance regarding virtual nursing. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Katie, welcome back.
Thank you for having me, Nick.
And happy Nurses Week to you.
Happy Nurses Week to you too, my friend.
In Season 3, Episode 23, you discussed care delivery model redesign and making the case for a tribrid approach. The third component in the tribrid model that you talked about is leveraging technology to reduce the burden of care for nurses. Now, we're recording this episode in advance of ANA releasing a document titled Principles of Virtual Nursing, which will be released by the time this episode airs. Can you talk more about this document?
We are excited because this has been a work in progress for some time. We have had some requests from other associations about virtual nursing. There's so much happening. A colleague referred to it as the Wild Wild West because it's being adopted so quickly and there's no authoritative statement or voice of principles in this space that will help give some guidance to institutions and nurse leaders that want to do right by this technology in their teams. So we went to work. And one of the things that happens at ANA that people are not very aware of, we don't just pick up things and start working on it unless it's an urgent thing or the environment calls for it. We also listen to our membership assembly, a group of our members from our constituent state affiliates, our individual members, our organizational affiliates. We meet in DC every June. So we have a meeting coming up in a few months. And they've directed us to make this a priority. We assembled an esteemed list of folks. We did an all-call for our membership, for people to apply to be on this professional issues panel. We did it in 4 to 5 months.
What is this? Is it a position statement? Is it a guide?
Yeah, thank you for asking. Our membership assembly told us that we need to work on defining what it is, establishing policy around a national policy about some standardization of practice, understand that virtual nursing practice is modality, and think about funding or reimbursement models, implications related to licensure, regulation, liability, establish principles around this, and also address the staffing component. For example, one of the things that they did say was virtual nurses should support but not supplant nurse staffing as it relates to ratios, matrices, or other measures of staffing levels. So when we assembled the group, we wanted to make sure that we were all on the same page and we wanted to establish scope of work. So one of the things that we decided to do was be very clear about what we're going to do because we figured that there could be some scope creep. And then the other thing was we started to delve into the discussions around, is virtual nursing more of a modality or is it a specialty? And we took the direction from the membership assembly and also talk to the group about how, maybe because this is emerging technology, let's talk about virtual nursing as a modality. We decided to create and publish a definition for it, understand and address implications for issues, but not limited to quality and safety, ethical concerns, financial, regulatory, portability of licensure, policy, staffing, and education, develop the principles, and then commit as a group that we will publish, promote, and disseminate the work products. So that's what we did.
I heard you talk about really 4 things: defining what it is, talking about standardization, the key principles, and then staffing. So when we're talking about defining, you mentioned modality, but beyond just it being a modality, what are we talking about? So we have a shared understanding when we use the words virtual nursing.
The definition that we came up with is this. Virtual nursing is leveraging remote technology and tools to provide safe and quality patient care through application of the nursing process by emphasizing communication, compassion, and collaboration through the continuum of care. There's a section in the document about whether it's a modality or a specialty. We're not saying that it isn't a specialty. We're just saying that for the sake of this work, we are saying that this is a tool, which is what you just heard in the definition.
Okay. That's helpful. And then beyond the definition, what's the next steps that you start working in that are of key relevance that a nurse executive would need to keep in mind as they're leading their organization?
We also recognize that there's an AI component to it because we know that there's some virtual technology tools that are being released that has some AI, which is great because AI is everywhere, particularly generative AI. And we want to make sure that there's clarity around the fact that this is not a replacement, especially when you think about the AI piece. It's not a replacement for nurses that are physically there to take care of patients in person within institutions. We do know that there's a component of virtual nursing where nurses may be remote in another building, another state, what have you. So those are all the things that we factored in here. But the number one issue was that we want to make sure that with these principles, we are making sure that our patients are safe and receiving quality care and that our nurses are safe and they're giving quality care. We did come up with about 13 principles. The document also has a glossary to make sure that we're level setting on some of the language that can give people guidance on how to use this work, because we were receiving calls, and I know I was, that I can attest to. I was receiving calls from nurse leaders that were going into their budget season for 2026, 25, 26. They were putting in their budgets to get the technology, but they're being urged by their CEOs and CFOs to understand whether this is going to replace FTEs. In some cases, we had to share our ideology and beliefs around what this technology means and how it's not a replacement. Because we're already in a hole when it relates to giving quality care because patients are sicker. When it comes to staffing, that's been pretty nebulous because we don't have a good way of measuring acuity real time. And patients, the way they present at the beginning of the shift by maybe an hour into the shift or maybe within minutes, that patient may have different needs that may require additional staffing or support. So we did not want to tinker with that. We feel that because of where we are and some of the challenges that exist when it comes to staffing and acuity and managing patient demand and all the other things that come with it, we want to make sure that this technology stays true to be seen as a tool. And
All
it's
right.
an additive tool to what already exists.
All right, so let's talk about that further. If I'm a chief nurse and I'm thinking about this document and it's a tool and it's not intended as a replacement, what I'm
Yes.
hearing is it's additive. I'm thinking about my care delivery model and the care I'm providing. This is not intended as budget neutral. It's not a replacement for the nurses. It's an additive tool, right? I'm
Mhm.
thinking, how on earth am I ever going to be able to afford this logistically? Because I've got a CFO that's telling me, hey, we don't know what's going to happen around Medicaid. Medicaid budget cuts may be coming. We're going to be in a much more difficult financial situation given the current emerging geopolitical landscape around funding healthcare and operating our business. As a chief nurse now thinking, maybe I can supplement or figure out a way to provide and leverage care at a more cost-effective means by potentially employing nursing that may actually increase quality at the same cost. But is ANA actually saying that this should be additive only? Is that my
At,
understanding?
at this point, absolutely. I think
Okay.
eventually organizations could get there with data and trends of data. They can see what may be opportunities for improvements in cost efficiencies. Nick, I worked as a CNO for years before I
Yeah.
joined ANA, so I totally get it. I understand when it comes to these technologies and investments, it's a trade-off. I want to emphasize that we have a lot of opportunity for improvement already, technology aside, to improve care. We know that mixed care is a thing in nursing, right? And in healthcare. And those are the things they don't typically capture. The only way any institution should consider off the bat reducing FTEs when bring this technology in is if they don't have any issues with miscare and quality of care. when it comes to adverse events and things like that. You'd be hard pressed to find one. This is a walk before you run piece. And I do think that there's a lot of data that's going to come out. There's more research that has to be conducted on the impact of virtual nursing on quality care and how you can balance and manage staffing. To reduce staffing, to bring this technology in is something that we advise against.
I want to continue on this trend just a little bit more. What if it's net neutral, right?
Mhm.
In other words, I've got 100 FTEs. I still have 100, and I'm able to deliver the same amount of quality, if not better quality, at that 100 because I'm leveraging the experience, really experienced nurses that aren't able to be at the bedside anymore, but their brain, knowledge, depth, and experience can really be leveraged to support our younger, less experienced nurses at the bedside. And if I'm able to do that in a cost neutral fashion, I still may be having some reduction at the bedside, but my net delivery cost is the same. Am I still understanding that in its true form against these key principles?
This technology is offered in a number of different ways. Some vendors that offer this where you don't, they provide this a turnkey. They provide the technology, the tools, the actual equipment, and they have the nurses because they already have these nurses in place and they're doing this in a number of other institutions. So they're not necessarily going to hire new for this technology. And the other thing I want to say is I think we need to remember this is not brand new. Like this is old. Well, how call it? It's kind of like a news card that they used to advertise where it's feeling like it's new, but it's not because we know that ICUs have had this technology for a very long time. We
Sure.
also know that some ambulatory programs have been using this. For tele-ICUs, I used to manage one. We kept our numbers the same while we had this technology as an extra pair of eyes. I think at the bedside, you can certainly keep your FTEs the way they are to start, but not necessarily think about removing FTEs to manage this technology. That would not be a good place to start. Let's keep things, trend the data over time, do the research and publish what we're seeing as we implement this technology. One of the things we don't do so well in nursing, unfortunately, particularly, there's a lot going on. People tend to get challenged with resources and things like that. We don't do enough, publish enough studies on these new things that we're doing, these innovative strategies for care delivery, changes to care delivery models. I strongly encourage institutions to publish your data. Let's see what you're doing, how you got there, what lessons you learned along the way. That's how we think about opportunities with the implementation of this technology.
What I hear you saying, and please correct me if I'm wrong, is if I'm a CNO and I'm trying to figure out here, where do I create my business case or my return on investment if I'm looking at implementing this, try to find your return on investment models, not necessarily around the labor component, but around the quality outcomes, the increase for reimbursement, or the ability to keep patients within your network, something around the quality component, the referral component, the volume component, not on the labor side. Is that accurate?
Look at institutions like Christiana Care in Delaware, like Providence on the West Coast. They've done a lot of work where they've looked for opportunities where they've struggled with providing, like, even with, I think there's one institution where they really use this to help with managing admissions, really make sure that there is support for nurses. The knowledge complexity gap is widening, right? In terms of patient acuity being so high, the years of experience in nurses that are competent, that have the experience that come to the table, that's dropping as well, particularly for nurses that are transitioning newly into practice. These are all the things we're still struggling with. We need to see this as an additive tool for now. Do the research, conduct the studies. Once you get the information and it's trending in a way that it's telling you that you're increasing quality and maintained or increased, nurse satisfaction is also maintained or increased, then you can see where the opportunities are. Given particularly as it relates to delivering care and nursing care, this is not a place to come off the table at the beginning to reduce FTEs.
Okay, that's very helpful. Thank you. I
No, it's
appreciate it.
great. But you're asking the questions that a lot of people reading this document are asking, right? It's already out there and people are wondering whether there's an opportunity. And I think, especially with the AI piece, there is, because I think that with the data collection and some of the things that we are challenged with in terms of understand where the opportunities are. So I do think that eventually, and the other thing that I want to mention that also is helpful, particularly with what we're seeing at Christiana Care, when they created their model and they have this homegrown program that they plan on taking to a national level, they have their nurses rotate through where they provide in-person care and virtual care. So they do both because this is their own technology. And they've seen it as a retention opportunity. Nurses get a break from being on the floor. They get to provide care remotely. So it does provide that type of, hybrid type of work environment that some nurses are looking for. So there's a retention and HR piece as well that you mentioned earlier that is also a benefit if you do a homegrown program. But if you contract with a vendor and they provide a full suite of services, it's really about how you can leverage the technology to improve care. We know there are a lot of opportunities for us to improve care that we're not getting to right now. And I do think that this will help with that. The future, I really do believe that any leader that's developing or designing their new care delivery model has to have technology in place. And Nick, you remember the last episode that I recorded with you, I talked about a tribrid model.
Yes.
I really believe that any nurse developing a care delivery model should have technology as one of their aids in that model. It's not all about labor. That's the future of delivering care, and the future is here. One of the best things I heard over the last week was the future is here, just not evenly distributed. The future is about how we can leverage technology to improve care and for us to also make sure that we're addressing the issues that nursing has had, where delivering care as a nurse has become more physically, psychologically, mentally, cognitively burdensome. And I really do believe that that is key for us to move forward so nurses feel delivering care at the bedside is not a pass through to something else. This is where they should stay and remain because this is who we are in terms of care. But because of all the struggles that nurses have had over the years, you find that they come into these settings, particularly in the acute care, and then they quickly want to move to something else because the work is not sustainable physically and psychologically for nurses. So how can we make it better? And that's where I think this technology is going to help with that.
So let's talk about the key principles. What are they?
We have 13 principles actually. And one of them is, and I'll read a couple of them out to you. First one is about safety and high quality care. That nurses are accountable for providing virtual care consistent with standards of professional practice with clear role delineation within the care team. Nurses should ensure that care is evidence-based, safe, high quality, and patient-centered. The second one is around our code of ethics, our 2025 code of ethics. It says that virtual care must be grounded in the code of ethics to ensure that all patients are treated with dignity, respect, and cultural humility. Nurses engaging in virtual care should recognize and address patients' individual characteristics, needs, and circumstances, inclusive of a cultural perspective to address health inequities. And the third one, nurses engaging in virtual care should validate the patient's and family's understanding of virtual care and advise them of their rights and responsibilities. So those are our top three, and we believe these will provide some guidance for nurses and any leader involved in implementing virtual care.
As you've been working with individuals that have helped contribute to this, is most of the work coming from within the hospital system, more on the ambulatory side, kind of a
Great
mix between the
question.
two? I mean, where are we seeing this delivery happening?
Mostly in the hospitals, but we were intentional of assembling a panel of folks that work in various settings. And we see that there's virtual care, virtual nursing opportunities everywhere in the ambulatory, inpatient, and post-acute setting. So we had nurse leaders from long-term care. We had a nurse leader from school-based care. We had someone from industry, a couple of people from industry. We had nurses from acute care. We had someone from correctional. We had a wide range of folks that helped us see everywhere where virtual nursing can be applied. Even though people may think that it only applies to acute care, it really goes beyond that because we want to open everyone's eyes to see this is technology can help in almost every setting. For example, in school-based care, many schools don't have nurses. We hear from our school nursing folks that there are a lot of children coming into school that need care. That care is becoming more acute in terms of the needs of some of these children. This is something that could help with some of the issues with pediatric patients that are in school or children that are in school that need some immediate attention, where the resources not physically in that school. but it could be certainly piped in from another location and make sure that some of those needs are attended to virtually, and then decide the next step, whether there needs to be some in-person care with movement resources around. Long-term care is another one. We have the long-term care staffing standards that came about. There is a need for there to be some RN oversight in long-term care. This can help with that as well. We really looked at this full landscape of where this could show up and how it can improve care across the continuum and in multiple settings. One of the things I want to make sure is understood about this final version that has been made available is that we did release it for public comment, and we did get a lot of feedback from a number of nurses from around the country. And we included considerations, consider the impact of AI, include language about informed consent. Make sure you're thinking globally, not just in the US, because there are folks outside of the US interested in this. Keep it as simple as possible. Make sure you have some consolidation and make sure there's not any redundancy or lack of clarity, and make sure that we broaden the language beyond the acute care setting. Lastly, policy implications, what it should mean for implementing this technology. Is there an opportunity for reimbursement in this space? So we do have some language in here about the policy implications, where we want nurses to flex their advocacy arm. And when they speak with their representatives and legislators, they talk about how this is technology about the future, which is here now. And we would love to see some funding and support for this technology. We should also push our government officials to support advancing care through bills and things like that. We really do feel that there's some policy implications that could be looked at as well, particularly as it relates to reimbursement.
Any closing thoughts as we wrap up this episode?
I'm excited about this release. We hope that people find it helpful. And we really do believe that this is what will pull us closer towards being more progressive in how we deliver care and expand this beyond places that we haven't thought of. This is really how we will be able to close some of the gaps that we've had that's plagued us for years, for decades. And let's not only implement it, but implement it with safety and quality and empathy and ethics to make sure we're doing this the right way out of the gate. That's really the take-home message that I like for everyone to have when they read this document.
Principles of Virtual Nursing has been our episode topic. The document is available now on the American Nurses Association website. Dr. Katie Boston-Leary, thank you so much for joining us again. Really appreciate your time today and look forward to reading that publication in the very near future. And for all of those listening, happy Nurses Week.
Happy Nurses Week to every nurse listening, and thank you for having me on your show.
Thank you.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.